Hello and welcome to this edition of Live and Ticking. The topic of today's event is an understanding sudden cardiac death. Every week in the UK, 12 people under the age of 35 are lost unexpectedly to sudden cardiac death. Sudden cardiac death is when the cause of death can be found in a post-mortem examination because something is wrong with the structure of the heart. Sudden cardiac death isn't a condition in itself, it's an umbrella term of which there are many possible causes, including sudden and fatal heart attacks and genetic conditions that can affect the heart's electrical system. Sudden cardiac death is often the first manifestation of an underlying heart condition, and it's important to note that this is very rare, and many people who have been diagnosed with one of these conditions go on to lead long and healthy lives with the right treatment and measures put in place. If you have a family history of heart disease or a known condition, you should consult your doctor for more information and advice. You might have seen we have a campaign around sudden cardiac death that's running at the moment. If you'd like to find out more, please click on the link in the chat box. Today, we'll be joined by Dr. Angeliki Asimaki, Senior Lecturer at St George's University of London, who is leading a new trial using regular cheek swabs to quickly and safely monitor children with a condition called arrhythmogenic cardiomyopathy, or ACM. ACM affects up to 1 in 1,000 people, and research suggests it could be responsible for up to 25% of sudden cardiac deaths in children. Angeliki's study uses this non-invasive method to track how a patient's condition is changing, allowing doctors to tailor treatment so that sudden cardiac deaths can be prevented. Afterwards, we'll be joined by Liz Rasdall. 3 years ago, Liz's 11-year-old daughter, B, began experiencing shortness of breath, dizziness, and an unusually fast heartbeat. As B's father and several other family members were known to have a gene alteration that can cause ACM, B underwent genetic testing and has now been diagnosed with the condition. B is taking part in Dr. Asimaki's trial. We'll hear more from Liz shortly. If you have any questions for our speakers today, you can submit them via the Q&A box throughout the talks. We will also be joined by Senior Cardiac Nurse June Davidson for questions later. We'll try to answer as many questions as possible during the Q&A. However, if we're unable to answer your question, then you can call our Heart Helpline and speak directly to one of our cardiac nurses. You can also join our Health Unlocked community forum for support. This forum provides a safe space to discuss living with any heart or circulatory diseases. All of our incredible research is funded 100% by you, the public. If you're inspired by what you hear today, then all donations to support our life-saving work are very much welcomed and appreciated. There's a link to donate in the chat box should you wish to do so. So before we hear from today's speakers, we'd like to ask for your support toward our Hearts Need More campaign. Over the past 6 decades, the UK has made huge strides in improving outcomes for people living with heart and circulatory diseases. In the wake of the pandemic and with unrelenting pressure on NHS services, this progress is now at risk. There are many people waiting too long for potentially life-saving heart care across the UK, putting people at higher risk of avoidable heart attacks, heart failure, and even premature death. That's why we're calling on the next UK government to prioritise heart and circulatory diseases. But we need your support. So to help us end the heart care crisis, we ask for you to add your name to our pledge today by using the link in the chat. Finally, before our speakers, I'd like to ask you a quick poll question. And how would you rate your understanding of sudden cardiac death? 1 is for very little and 5 is a lot. I'll just give you a little moment to register your vote. And that's before we introduce our first speaker today, Dr. Angeliki Asimaki, who will talk us through how analysing patient cheek swabs will give doctors an insight into their hearts. Over to you, Angeliki.
Thank you very much for inviting me to this event. It is a great honor for me to be here today. So first, just a little bit about me. I was born and raised in Athens, in Greece. I completed my undergraduate studies at Queen Mary, University of London, and I started a PhD in cardiovascular medicine at the late Middlesex Hospital behind Good Street in London, which has now been demolished. When I was a second-year PhD student, I was given the chance to spend 3 months at Harvard Medical School in Boston as a visiting scholar, and these 3 months turned into 11 years of my life. So I completed all my training in molecular cardiovascular pathology in the States, and I moved back to London in 2017 to get an independent position at St. George's University of London, where I am now a senior lecturer in sudden death. The choice of my field was practically natural for me, given how I have personally battled heart disease my entire life. I was born with not one, but 2 separate congenital heart defects, and to date, I have survived 9 heart operations and a stroke. My heart only functions on batteries, and in fact, I'm now going through my 5th pacemaker generator. Apologies if I repeat some of the information that Fearghal already said. I would like to put sudden death in numbers. Every week in the UK, more than 12 apparently fit and healthy individuals under the age of 35 will die suddenly due to a heart disease they did not even know they had. And if we look at the worldwide statistics, sudden cardiac death accounts for more than 4 million deaths every year. There are 2 major classes of diseases that typically underlie sudden cardiac death. We have the cardiomyopathies, a group of diseases that affect the structure of the heart, and the cardiac channelopathies, a group of diseases that affect solely the function of the heart. The remaining cases that cannot be classified under either of these 2 categories are termed SADS, sudden arrhythmic death syndrome. Now, I have dedicated the past 20 years of my life to the study of arrhythmogenic cardiomyopathy, or ACM, which is a major cause of sudden cardiac death in all populations of the world. It was originally estimated that ACM affects 1 in 5,000 individuals in the general population, but more recent studies show that this is probably an underestimation, and the true prevalence lies between 1 in 1,000 and 1 in 2,000. ACM is strongly heritable, it runs in families, and it is characterized by the gradual degeneration of heart cells, depicted in red here, by fat in white and scar in blue. More than 60% of ACM patients have a DNA mistake in the desmosome. The desmosome is a mechanical bridge that holds the heart cells together. It is made of 5 proteins. Think of them as building blocks, as bricks of the bridge. And we have plakoglobin, plakophilin-2, desmoglin-2, desmocolin-2, and desmoplakin. When one of these bricks has a DNA mistake, the bridge is weakened. As a result, the heart cells detach and die. And because our heart cannot regenerate, the gaps will be filled with fat and scar. Consequently, electricity cannot flow through the heart smoothly, causing a very abnormal heart rhythm that can lead to sudden death. Now, despite decades of research, the diagnosis of ACM still remains highly challenging. The golden standard would be to examine a piece of the heart and identify those areas of fat and scar. However, getting a biopsy sample from the heart is invasive, very risky, and very rarely performed. And even in those cases when we do perform it, fat and scar is present in the patients with advanced or very severe forms of the disease, not so much in those that have early or milder forms of the disease. Now, when I was based in Boston, we spent about a decade examining heart samples from hundreds of victims of sudden cardiac death. And we found that in those people with ACM, certain proteins, bricks, have moved from their normal position to a different location. The major example is plakoglobin, one of those desmosomal bricks I referred to earlier on. This is a heart sample from a healthy individual, and you can see that plakoglobin, depicted by those white lines, lies where it should be, connecting the heart cells to each other. but these are heart samples from patients with arrhythmogenic cardiomyopathy, and you can see that the white lines are virtually eliminated. Placoglobin does not make it to the junctions. Another example is connexin 43. This is the protein responsible for conducting electricity from one cell to the next, making sure that the heart contracts in a synchronous manner. In the heart of patients with ACM, connexin 43 is again gone from those bridges, and it is gone even in very early forms of the disease before the fat and the scar appear, which can explain why people can still die even with an early form of this disease. I will not bore you with more protein markers, but I can tell you that by examining where 6 proteins lie, we established what I like to refer to as the molecular signature for this disease. So when somebody died suddenly, if the cardiac pathology examination was inconclusive, we could look where these 6 proteins are and know with certainty if the person had ACM or not. This was incredible for establishing a cause of death in young victims and for making management plans for surviving relatives. It was not, however, particularly useful in living patients since it required a piece of their heart. Now, there is a liaison between the heart and the skin because they come from the same progenitor cells during our embryonic development. And in fact, if a patient with ACM happens to have 2 DNA mistakes, then chances are that he or she will also have skin abnormalities like those shown in the picture in addition to their heart disease. So a few years ago, we discovered that the same proteins that move from one location to another in the heart of an ACM patient also do so in their skin. Now, getting a full thickness skin biopsy is by no means as invasive or dangerous as a heart biopsy, but it is also not particularly pleasant. But what about the inside of the cheek? This is a specialized form of skin. We thus got to the point where we can use a Q-tip or a very soft brush. We can rub the inside of the cheek, spread the brush on a microscopy slide, look at it under the microscope to see where the proteins lie, and diagnose a deadly heart disease. And at the beginning, we looked at more than 100 adults with a diagnosis of ACM, and we established that all of them have no signal for placoglobin or for connexin 43 in their cheeks. And we also showed that depending on where the DNA mistake was, they could also lose signal for desmoplakin or for plakophilin. Now, this was in adult patients that already had a diagnosis. But for years, we wondered what happens before the disease strikes. See, most patients will silently carry their DNA mistake for several years and only start showing evidence of the disease in adolescence. But what happens earlier on? And what happens as the disease progresses? What happens if the patients are prescribed medication? Up until now, the only way to address these questions would be to get serial multiple samples from the heart. Now, getting a biopsy from the heart is very dangerous. Getting multiple biopsies from the heart is out of the question. And getting a biopsy from a child that just carries a DNA mistake and does not even show any signs of the disease yet is even more out of the question. But getting multiple smears from the cheek, it is easy, totally non-invasive, and totally risk-free. When I moved to London in 2017, I was awarded a small pilot grant from the Rose Trees Foundation to analyze serial cheek smears from children of ACM families followed at the Great Ormond Street Hospital. And here is what we found. ACM patients are born with the DNA mistake. So one would imagine that all those proteins I spoke about would have moved at birth. Surprisingly, this is not the case. Proteins start moving only around the time that the children start showing the first signs of the disease. In children that do have no evidence of disease yet, all the proteins look absolutely normal, just like in a child without any heart disease. Secondly, more proteins are shifted as the disease progresses. And here is an example. In 2019, we examined a cheek smear from a 10-year-old boy. At that time, he only had small changes in his electrocardiogram. Only signal for connexin 43 was gone from his cheeks. The rest of the proteins looked just fine. A year later, the boy came back for a follow-up. At that point, there were more abnormalities in his electrocardiogram, and placoglobin was also gone from his cheeks. And a year after that, his heart was getting worse. Now the left side was enlarged and it was not contracting properly anymore, and signal for plakophilin was also gone. Lastly, patients with ACM are mostly managed in two ways: medication and defibrillators, devices that are implanted in the chest, and when they sense an abnormal heart rate, they shock the heart to restore the sinus heart rhythm. One of the major classes of medication we prescribe for ACM is beta blockers, and they do help. But how? Here is a cheek smear from a 14-year-old boy who had a lot of arrhythmias and no signal for connexin 43. Remember, this is the electrical conductor in his cheeks. The child was treated with a beta blocker called bisoprolol, and 4 weeks later, signal for connexin 43 is perfectly restored. So we were able to show at the molecular level what that drug did to eliminate this child's arrhythmias. To summarize, we showed that the distribution of key proteins in the cheek is dynamic. It changes over time. More importantly, it correlates with disease onset and disease progression. So we can use something as simple as a cheek smear as a prognostic tool to confer risk stratification in children of ACM families and guide our management options accordingly. And we showed that connexin 43 localization can be restored in response to an effective beta blocker. So cheek smears can also be used to assess effectiveness of medication, not just at the clinical level, but also at the molecular or the cellular level. We took this pilot data and submitted it to the British Heart Foundation, and the BHF kindly granted me an award in September 2023, which has now allowed me to recruit many more children and follow them longitudinally over the 3-year period of the award. With the help of the BHF, we are now proud to say that we have enrolled 120 children in our database, and more are added every week. As for the future, here are my 3 main goals. Although many patients will first manifest disease in childhood, others will start showing some signs in late adolescence or early adulthood. So I'm now planning on expanding the research beyond the Great Ormond Street Hospital to adult hospitals all over London, including St Thomas's Hospital and the Royal Brompton, and hopefully all over the UK. Secondly, I developed a pilot home kit that would allow patients that want to be monitored to obtain their own cheek smears at home and just post them to me for analysis, sparing them the burden of additional hospital appointments. And finally, I'm currently expanding the principle of translating findings from the heart into the mirror to the cheeks, to patients with other diseases, so that eventually the cheeks can help the heart of much larger populations of people battling heart disease. At this point, I would like to deeply thank the BHF for their invaluable support, and I'm looking forward to answering all your questions. Thank you very much for your attention.
And Angelika, thank you very much indeed, and for sharing your own story too. Our next speaker is Liz Rasdall, who's going to share her experience as a mother to 11-year-old B, who's taking part in the cheek swab trial. Liz will also be joined by Ruth Huntman from the BHF Heart Stories team. Welcome, Liz and Ruth.
Hi, everyone.
Thanks, Fergal.
Hi.
Hi, Liz. Thanks, Fearghal. Thanks, Dr. Angeliki. That was fascinating. So, Liz, as Fearghal said, your daughter B, who's now 11 years old, was diagnosed with AMC and is now taking part in Dr. Angeliki's clinical trials. It was quite remarkable how you discovered the condition in your family prior to B's diagnosis. Can you sort of briefly tell us about that road to diagnosis?
Sure. So basically, we found out that B's great-grandmother had had a baby before she'd had her other children during the war and given that baby to her brother. And so it materialized that who they thought was their cousin was actually their brother, so my granny's brother. And so as a result, the children on that were from I suppose the great uncle were much closer relatives. So some of those children had ACM, and then B's grandma was tested for it when she realised that it was her brother rather than her cousin that probably had the disease, and she was found to be positive. And then both my husband and his brother and his sister were also tested, and the brother and my husband were found to have the same gene that causes AVRC. So B, when she was 2, was seen by Great Ormond Street, and they also found that coincidentally she had a mitral valve cleft at the same time. So we were then followed up yearly by Great Ormond Street. And then I think B was about 3 years ago, B started to experience some symptoms. So she had some tachycardia, she felt a bit breathless, and she had sort of abnormal rhythms that she felt. And so we'd had some of the monitors that are put on for 2 weeks to sort of see what they would pick up, and on those it was found that she was having ventricular tachycardias, which is very rare in children. So as a result of them, she started on some beta blockers, and we had the genetic testing done on B as well to see whether she had the gene, which she does. So yeah, so she's on beta blockers now, and she's ended up with a loop recorder so that we can see what these abnormal rhythms are, and pay a bit closer attention to them. So yeah.
Presumably you knew little or nothing about the condition before your family was affected by it. It must have been a huge shock, especially I can't imagine how stressful it must have been sort of finding out that your daughter also has the gene. So how did you process that, and sort of what was your immediate fear, sort of what went through your mind?
Yeah, I think I'm quite pragmatic about it because I'm a nurse myself and I did palliative care for a long time. So I think that probably really helped that I was quite pragmatic and I was able to sort of think, right, well, what are the risks? What do we know? Where are we at? And sort of able to think about it like that. But yeah, of course, it was really worrying. And I think my husband particularly felt very that he was to blame for it. And that was really difficult. I think he felt very much like he was carrying the gene and he'd passed it to her. So it was a lot of reassurance, and actually knowing about it is, knowledge is power, and actually being aware of it made us so much more fortunate than all the families out there that don't have any clue that they have it. At least with B, we can monitor her, we can see how her heart is, yeah, and just sort of know where we're at. So yeah, I think it was a real shock, but actually I think as a family we were able to sort of work together and give B the information, so B has a really good understanding about her heart. She understands about what the gene is, and it's all really age appropriate. So we're just taking it, and as the years go by, we'll build on that and give her more information. And she asks lots of questions, and she can't hear me today because she's at the theatre with her granny. But otherwise, she would definitely be here and be telling you all about what she knows. But yeah, she's really knowledgeable, and I think just being really honest with her and open means that it's not scary, that she's not afraid. And she knows that when we get given information, we'll share it with her. So yeah, I think that really helps.
Yeah, no, that sounds absolutely perfect approach. How did you find out about Dr. Angeliki's trial, and sort of how did you get involved? And I mean, hearing about it for the first time, it's incredible. So I can't imagine what it feels like to sort of be part of it.
Yeah, so we were approached by the research team at Great Ormond Street in the cardiac department about the study, and I think we signed up almost straight away. B was asked whether she would be interested, and she was like, well, hold on, what have I got to give? And they said, well, some samples from your cheek and a blood test, but we're doing a blood test anyway, so there's no extra blood taking. So she was like, fine, I'm sold, I'll happily give some. So she gave some urine, some skin swab samples, and a blood test. So she was more than happy to do that. And then every time we get seen at Great Ormond Street, we give more samples. So every time we've had a swab test done since then. So we must be on quite a few by now. She's become quite the whiz at doing them. Yeah, she doesn't mind. And I think what's really nice about it is that B very openly says it's not invasive, it doesn't hurt, it's a 2-second job. it's quite fun. She doesn't mind doing it. And I think that that's the real difference, is that for lots of children, B in particular, she was quite fearful of hospital. She didn't like having blood tests done. She was very worried about it. She needed a lot of talking around to it. So I think to have something that's just really easy and simple and doesn't hurt, it is really effective. And, you know, in the long term will mean that children won't have to go necessarily into hospital to have tests done. So I think that's life-changing, really.
Absolutely. I mean, is there some way in which she feels quite special, and does she have an understanding, even at her young age, that, you know, what she's doing is really pioneering and helping others like her in the future?
Oh yeah, she loves being the fact that she's doing all the research. She's really keen on it. We were interviewed by TV recently, which she greatly enjoyed because she'd like to be an actress. So she was very much the star of the show. Very amusingly, her brother is also doing the study now. We signed him up for it. We don't know if he has the gene, but we'll find out at some point in the future. And he was asked in the interview, bearing in mind they'd been there with us for like an hour, and we were talking about the study. And then he was asked, "What do you think of the study?" And he was like, "What study?" And then I was like, "Remember you had the cheek swab?" "No, I don't remember it." So B said, "Well, that's the answer, mummy. Like, he doesn't even remember having it, and he definitely had it when we went, 2 months ago." So I think that just shows you how not bothered by he was, and he's 6, so he totally wasn't even remotely bothered by it. But yeah, I think it's really nice that she's done a little talk at school about it, and yeah, she just finds the whole thing really, really positive. I think that she's able to sort of spur the way for the future.
I mean, talking of the future, this is a really sensitive subject, but I know you're fine talking about it, because as you say, because of what you do, and you're very pragmatic as a family. But obviously there are implications as B gets older and reaches womanhood, in terms of deciding whether or not to have a family. I mean, I guess it's too early to kind of broach that now, but is this something that you've thought about and sort of concerns you, or?
Yeah, I mean, we were really lucky because when we saw, before we had the bloods test done for the genes, we spoke to a geneticist, which was really, really helpful. And she was really honest with us and said, fertility treatments are changing all the time. And actually, what will be available by the time B becomes of an age where she could go on to have a family will be very different to where we are now. So I think that's really, really reassuring to be able to think about what the future might hold for her. And she may choose to have a baby without doing any genetic testing, which we would support, but I hope she'll at least look at the options and think about it. But I think it just goes back to that thing about knowing about it and knowing what you can get, I think, is really important. And I think we had Frank after we knew about the gene, but I don't think we'd really had it talked to us about. So I think that's one of the things I would definitely say, is that I think knowing about it and getting those chats in early is really important. So yeah, I think knowing about it, being able to talk to her as she grows, means that hopefully it won't be a bit of a shock. I think it's much shocker, isn't it, if you later on you hear about it and you had this plan in your head about how it would be. So I think being able to sort of talk about it would be really helpful. But it's definitely something that plays on your mind a little bit.
Yeah, for sure.
Yeah, but I think hopefully she'll be fine.
Yeah, well, I saw the television piece, and she looks like she's well able to cope with much of what life will throw her. Finally, Liz, and can I just ask you, going to put you on the spot here, but you've never met, am I right in thinking you've never met Dr. Angeliki before this?
Yeah.
So, firstly, what was it like to actually meet the person behind this trial, and what would you say to her and sort of others like her?
Oh, well, I just think, I think the thing is, anyone doing research is so important, and it can make a real difference to patients. And I think, this study has such great implications for the future, for children in the future, for adults in the future, and also as a sort of cost-saving measure in the future as well. Let's face it, we want to save money where we can in the NHS. So there's so many really wonderful things I think can come out of it, and that reassurance for families, I think, is massive. Being able to sort of monitor where children are at and know, well, at the moment there's, the skin swab showing that there's nothing, so actually probably everything's fine. I think that reassurance is worth its weight in gold, really, because then you've got a way to sort of know where we're at. Do we need to be seen by somebody, rather than a bit of a stab in the dark? And I think for B, one of the big things I think for her was her symptoms are very similar to normal anxiety symptoms, and of course she was worried about her heart, so therefore she got more symptoms because she had really genuine normal worries. And so I guess some of that can be waylaid by, well, we had your swab last week and that showed that everything was, pretty good. So I think, yeah, the research work is just amazing. And I would thank you, Dr. Angeliki, for everything that she's doing, because it's so important. It can really change the way that children are treated in the future, and grown-ups too. And I think, yeah, just keep doing what you're doing. It's amazing.
Cool. No pressure. Thank you so much, Liz, and for being so candid. And please send all our love to Bea as well.
Oh, I will do, absolutely. She's so cross, she's missing it, honestly. She's
There'll be other opportunities, I'm sure.
Yeah.
Thank you, Ruth, for guiding us through, and thank you, Liz, for your strength and clarity, actually, of the way that you've reflected your story. We really appreciate you sharing it with us today. Now, we're going to welcome back our speakers for the question and answer portion of the event, along with Senior Cardiac Nurse June Davidson. And as you'll know from watching this webinar in the past, we go for the most upvoted questions first. So the first one will be to you, Angeliki. And don't forget that we have some questions in, but of course we'll have room hopefully for more. Obviously you're trialing, Angeliki, but do you think one day the cheek swab test could be used for genetic testing to diagnose ACM?
So the cheek test cannot be used as a genetic test. It can give you as I mentioned in the talk, 60% of the patients have a DNA mistake in one of the 5 desmosomal bricks. If two of them has the DNA mistake, there is a specific pattern of things that change in the cheek, and then one of the other 3, if there is a DNA mistake there, then there is a slightly different pattern of proteins in the cheek. But still, it doesn't tell you precisely where the gene is, and by no means it is not capable of telling you what exactly the genetic mutation is. I mean, is it just a small change in the code? Is it a massive change that leads to the protein not being made at all, or being made and being degraded? So it was never designed it can give you an idea, right? But then again, if you don't have a DNA mistake in any of those 5 desmosomal bricks, then you still get abnormal results in your cheek, but without any indication as to where the mistake is coming from. It was never designed to replace genetic screening. It was designed originally as a diagnostic test, and mostly for those cases that are ambiguous, because when the disease is pretty severe and advanced, the clinical modalities that we have in place at the moment are pretty good at establishing an accurate diagnosis. But when you have mild forms of the disease or very early forms, there are abnormalities, but still you don't exactly meet the diagnostic criteria. So we were trying to fulfill this unmet clinical need, the ambiguous cases or the early cases. So it was made, and it works as a diagnostic test. And it was only after starting the child study that we realized its power as a prognostic or as a risk stratification test as well. So those are the directions we're focusing on.
Okay. Second question for you. Is there a way to correct the DNA mistakes that causes ACM before it damages the heart and allows the fat and scars to form?
Very, very good question. There is gene therapy that can be done. Now, that being said, gene therapy is still in its infancy. And we need to bear in mind that there are a lot of factors that need to be taken under account. So understanding which is the faulty gene is the easiest, the first part. But then we need to create a virus, basically, which is non-infectious and contains the correct form of the gene without the mistake. But then we need to figure out, how do we deliver it to the heart? Do we deliver it with an injection in the heart? Do we deliver it with an injection through a coronary artery? Do we deliver it through the vein? How often do we deliver it? Do we give it every 6 months? Does the product even get incorporated in the heart? If it gets incorporated, is it toxic down the line? So there are a number of things that need to be addressed. But at the moment, I can tell you that there is a company called Teneia Therapeutics in the States that is launching the first clinical trial of gene therapy for patients that have mutations in plakophilin 2, but it's phase 0. So at the moment they have enrolled, I think they haven't, they're about to enroll the first 5 patients in the world that will get this done. But I am with the way that technology and medicine is progressing, I actually have no doubt that all these questions will be answered and that this will be a therapy that can be available to much larger populations over the next few years.
You're getting a lot of questions, Angeliki. So
Fire away.
once the trials have finished, what are the next stages of your research?
The chance to finish.
Once it's finished, what are the next stages for your research?
I don't want it to finish. First of all, I know the current award that I have takes me to September 2026, and then I am gonna, because it is a longitudinal study, I do not want to give up on those kids like B that I have swabbed 6 times to this day. Yeah, and I basically want to find more funding, and I want to continue this. I want to enroll every single child that walks the doors of Great Ormond Street Hospital with a history, a family history of arrhythmogenic cardiomyopathy. And I want to, I already said the 3 things that I'm planning on doing. I want to launch the home kit, because at the moment, children are seen at GOSH once every 6 months or once a year. And from a clinical standpoint, this is good enough. But perhaps certain families are more anxious and they would like to have a reassurance more often than once a year. And I do not want to have to drag them to the hospital to have their cheek swabbed every month. But if the home kit becomes widely available, then they can by all means swab themselves every month and they can post the samples in. I'm completing the ethical approval part to add a lot of satellite centers to my study. So now we're starting to add many more hospitals. And I keep doing research. So now all of that is basically implementing something we already know. But the big research question for me now is, can I apply this to other heart diseases? Because yes, ACM does account for 25% of pediatric sudden cardiac deaths, but there is another 75% that I still want to save.
And an anonymous attendee is asking, does the cheek swab identify the level of risk of SCD? And if so, how does it do this?
Very good question. The way that I optimized this technique when I developed it is I wanted a binary result. So from the images that I showed, I think it was pretty clear that the protein is there or it's not. I never really liked the grading idea of this. Oh, it's a grade 1 loss or a grade 3 loss, because this is not very easy to be reproducible by other labs. And the idea is that once at the moment, me and my team, we can handle the 120 children. But when this goes bigger, and ideally when this spreads to the world, we are not going to be able to do all the workload ourselves. So we are going to want to share our technique with everybody that wants to do it. And grading, especially different centers, different microscopes, different users, is going to make it quite difficult. So the way the technique is right now, no, it does not give you the level of risk. But it definitely, as the proteins move away one after the other, each loss is a slight increase in the risk level.
Okay. Question for you. Thank you, Angeliki. Question for you, Liz. And how did, everybody wants to know the personal story in this, and it is, how did B take the news of her diagnosis, and how has it affected her childhood, your family life?
So I think when she was first told, I think she did get a little bit upset. But I think because we're really open and honest with her, she doesn't have the fear. She sort of understands that it's a condition. We need to keep an eye on it, and that if you didn't know about it, you can die suddenly. But because we know about it, we will be able to sort of monitor her and put interventions in place to prevent that from happening. So I think not being scared for me was the most important thing. For her to understand, have a good knowledge base has really helped her. So she doesn't, like, her childhood is completely normal. She does drama, she does swimming, she does yoga, she doesn't do a lot of sport because she doesn't really like it, but her brother on the other hand does every sport imaginable. So I think it's really about us just being really honest with them and explaining, in the future there might be things that you can't do. We've sort of talked about that, there might be some things that are less safe for you to do, depending on what happens. But I think we've just tried to be really, just really honest with her, not put blocks in place when we haven't needed to. But yeah, so she has I would say a pretty wonderful childhood. She's completely fine, and I think she just considers herself to be quite, have a bit of a special heart. She's got a little funny cleft, and she's got these funny beats that she gets. But I think as well for her that having the loop recorder has really helped, because that's given her a lot of support around knowing that if she has a funny rhythm, she can mark it, and somebody will look at it later at Great Ormond Street to check it's okay. And so that's given her a lot of reassurance as well. So I think probably the two things have really helped. Yeah.
Yeah, and another questioner is asking you, Liz, has the whole family been genetically tested, and what impact has ACM had on the family as a whole?
Yeah, so I think all family members have been tested now, apart from our son. So he'll be tested when he's a little bit older. The reason that B was tested earlier was mainly because she was having these symptoms, and our consultant felt it would be useful to know if she had the gene change, because she was having these sort of these ventricular tachycardias. So it was it wouldn't change our management of them, but it would just be useful information to have, which is why we did it. But for Frank, we want to give him some autonomy. So we'd like to be at an age where he understands what we're testing for and that he can make a decision. B was included in the decision, but we sort of encouraged her to have it. Whereas with Frank, I think we'll probably try and be more, look, we can find out about it, we can not find out, these are the pros, these are the cons. That's kind of where we're sort of thinking that would be, which is what we had planned to do with B as well. So yeah, I think because obviously you can have the gene, but your heart can be completely unaffected. So it's a bit of a tricky one to sort of make a decision about. But my hope is that Frank will agree to be tested in the future. But the rest of the family have been tested. So out of the 3 siblings, my husband has the gene, my brother-in-law has the gene, but my sister-in-law doesn't. My brother-in-law has a defib fitted, so he is affected and has defib, but my husband has the gene, but his heart is unaffected. So yeah, so I think we're all acutely aware of it, but I think we just try and live life really, and just enjoy every day. I think that's all we can do.
Another 2 for you, but they're linked. One is, how long to get the genetic blood tests in the first place for B, and how long to wait for her results?
So with B, we'd always had a conversation that we would wait until she was a bit older. But when she started to get symptoms, Dr. Keski, our consultant at the time, sort of thought it would be helpful. So he asked us whether we would think about having it. And so we talked about it as a family and decided that we thought it would be a sensible thing to do. We talked with it to B. So it was arranged on the same day that we went down for our normal tests. So the test was done on that day, and we saw a geneticist the same day and did the test. And then it took around, I think they said 3 months, but I think it came back after about two and a bit months, and we had a video video meeting with a geneticist to let us know the results. That was all sort of through COVID as well, so it was a bit trickier. But yeah, I mean the appointment was really useful. The pre-appointment was really helpful, and then the post-appointment was helpful, just letting us know that she did have it. And we were able to ask any questions that we had, and get some support. And yeah, it was really, really well handled. It was fine. But yeah, I think the results take about 3 months, roughly.
Perhaps a question for you, June, and welcome. How prevalent in the UK population is ACM?
Well, I think Angeliki alluded to that in her talk. I think we thought it was a lot rarer than perhaps it is. So I think recent statistics are sort of saying, correct me if I'm wrong, Angeliki, but roughly about 1 in 1,000 people. I think prior to that, we thought it was much rarer, actually. I mean, it is still relatively rare, but again, as Angeliki said, it is a significant cause of sudden death in young children. So really puts the spotlight on why this research is so vital, to try and put an end to these tragic and sudden unexpected deaths when you might least expect it.
Yeah. And what's the difference between ACM and other types of cardiomyopathies? An anonymous attendee is asking.
Yeah, so cardiomyopathy is like the umbrella term, which means heart muscle disease. ACM being one of them, and that's where, as you've heard, that the sort of cells in the heart don't stick together properly, causing it to weaken. There's another very common type, which you may have heard of, called hypertrophic cardiomyopathy. That's the most common one. And that's where you get thickening of the actual heart muscle. And then we have dilated cardiomyopathy, which is where the heart becomes enlarged. That tends to be that they are all genetic potentially, and they all potentially are inherited, but dilated is one of the ones where you may have from kind of an environmental, or you might get it from a virus or drinking excess alcohol. So that one tends to have other different causes, but in the main, they are all kind of genetic and inherited diseases, and can cause, some people live a very long and healthy and happy life without any kind of symptoms at all, which is obviously great. But other people will experience some symptoms, perhaps some palpitations, perhaps some breathlessness. And then sort of the far end of the scale, the sort of real tragic cases that we do here is that it can, in rare cases, cause sudden cardiac death, which again is why this research is so vital.
Yeah, and of course, you've just touched, we're all touching on the research, and other questioners saying it's a great event, and I'm sure you're talking to people, families with conditions and individuals with conditions all the time, but they're asking, what can BHF do to support families with inherited heart conditions?
Yeah, so we have our helpline, which is run by cardiac nurses, but we also have a sort of a sister arm to the helpline, if you like, called our Genetic Information Service, and that is staffed by specially trained nurses in genetics, and we can help support people and their families who have an inherited heart condition, or who may be at risk from one. And I'm talking about cardiomyopathies, but I'm also talking about other inherited conditions like the channelopathies that Angeliki mentioned, perhaps the sudden arrhythmic death syndrome, people who've had a very sudden cardiac arrest out of the blue. So we can offer information and support to families. And if somebody's struggling to get the support they need, we can also help support them get an assessment at Specialist Inherited Heart Condition Centre. So if anybody listening, if that applies to you, please get in touch via our website, and we can provide you with help and information.
Yeah, and all that information is, for anybody watching, readily available on our website, as June says. A specific question around symptoms of ACM. If you didn't know you're at risk genetically, are there any symptoms to be aware of?
You're asking me that one?
Yeah.
So it can be tricky, because the symptoms of cardiomyopathies can be the symptoms of many things. So, but some of the kind of telltale things to look out for, if you're experiencing regular palpitations, and you get diagnosed with an abnormal heart rhythm, if you're feeling faint or lightheaded or dizzy, and that's happening more frequently, or if you're getting repeatedly breathless, if you suddenly start to feel very tired. They're all kind of classic symptoms of a cardiomyopathy and ACM. But as I said, it can be a symptom of many different things. I think one of the key things is to be aware of your family history. So if you do have a family member who's died suddenly, particularly at a young age, and there's been no underlying cause, or no cause of death has been established, that's a very big kind of red flag. So do get in touch with your GP if that's the case. Yeah.
Angeliki, and another layer of this, does ACM affect certain ethnic groups more than others?
No, I wouldn't say so. Not ethnic groups. Well, it's there are slightly higher numbers of ACM patients in Italy and in the Netherlands, but this is mostly due to founder effects. This means that the population was very small a long time ago, and there was one patient zero some 800 years ago that had a mutation, and then all the following generations got them, and then this was a country that remained basically small and remained within the confines. So people kept marrying each other from the same country, and so we end up having larger numbers. But in terms of ethnicity, no. In terms of genetics, of course, the heritance is equal between males and females, but there is a tendency for males to be more affected. So they either have slightly more severe forms of the disease, they have a slightly earlier onset, so the first symptoms might come a little earlier in life, and From those people that carry the DNA mistake, but they never manifest any evidence in life, slightly more of them tend to be women.
Okay. You did touch on your personal connection to the disease, and is that what interested you particularly about this area of research?
Absolutely.
Yeah.
And when I wanted to start my PhD, I specifically inquired about doing a PhD on people like me. And I was told at the time that the incidence of the combination of what I have is 1 in 2 million, and I will never get any funding to do this.
I like your style.
But at the time, ACM research was at its infancy, so they had actually only identified 2 genes. So things were only starting, which means that there was a lot of space for people like me that were very passionate about any kind of cardiac research to go in and just start finding things, which is why I focused all my efforts and passion into this instead.
Okay. Another question, we're touching on the gene. Are there factors that could trigger expression of the gene? And why are some people unaffected by the gene and others are not?
This is a great question. We do not have a very definite answer to this, but we are certainly aware of the fact that exercise is perhaps the most important factor in making the disease wake up. And so usually there are twin studies that carry exactly the same genetic mutation, and the one that is sedentary will have a much milder form of the disease or will not show evidence of disease at all, compared to a twin brother that is an endurance athlete, and this person is at much higher risk.
Wow.
Other factors that we believe could influence this is the general genetic makeup of the person. So we believe that when a gene is not functioning well, the body itself has backup mechanisms that step in and they help to fill this gap that is being created. So other small changes that you might have in your DNA makeup on their own, they might not be pathogenic or mean anything, but if you do have a gene for ACM, all of them will play a role as to whether you will express the disease or not.
Right. Another questioner is saying, I appreciate all our systems are interconnected, but what role, if any, does the immune system, the nervous system, and the emotional system have on ACM?
Another great question. The nervous system, not much that I am aware of. The emotional system, like with every single disease, it definitely plays a role. So the levels of stress, I imagine that they can add to the risk. The immune system, this is a very new area of research, which we basically, so there is a lot of inflammation in the hearts of patients with arrhythmogenic cardiomyopathy. In our post-mortem series, up to 80% of the hearts that we look at from ACM people, they have strong evidence of inflammatory infiltrates of immune cells that go and reside in the heart. And up until perhaps 3 years ago, we believed that this is a consequence of the disease. We believed that the death and destruction that happen in the heart, all these cells that die and you get all the fat and all the scar, this triggers the immune response and brings all the cells to the heart. It turns out that it might be the other way around. We now have a lot of lines of evidence suggesting that it is inflammation that is actually driving the disease. And the disease, the way that usually the progression goes is you might have very long periods of time where the disease is very quiescent, very shy. And then there is what we refer to as a hot phase. So there is some sudden deterioration. So a few days where the patient might feel more palpitations or feel worse than usual or have a syncope episode. And then again, the disease will stabilize for another long period of time. Then you have, so in my eyes, the disease progresses stepwise. It's not exactly a line that goes downwards. There are steps. And we believe that each one of these steps is actually triggered by an immune response. So we think it's an inflammatory episode that causes one step down.
Shar McDonald's asking, is there a link between AF and ACM?
No. There's a very small subset of diagnosed ACM patients that will have atrial fibrillation, and these are usually cases that are very severe and very advanced, where the entire heart has become very dilated and where the patient is going into heart failure, and this is what's going to trigger secondary atrial fibrillation, so a consequence of ACM.
Okay. A comment more than a question, and it's this person saying, Francesco Palma, saying that the National Screening Committee in the UK doesn't recommend screening as SCD in the 12 to 39 years of age, account for only 1 to 2 cases of 100,000 population. Is that a dynamic in your terms?
Shall I come in on that one?
Yes, June, yeah.
Yes.
So yeah, I mean, it can be quite controversial, but the UK National Screening Committee don't recommend population-wide screening. Because as you said, Fearghal, and it is a position that the BHF supports, because there are questions still around the reliability and accuracy of doing that. For example, when somebody's tested, they might have a normal result, but actually it hasn't actually picked up the heart condition, or it might be the other way around. So sometimes athletes in particular train very hard and they develop some maybe changes in their heart muscle, which isn't necessarily harmful, and it's inaccurately picked up a condition. So at the moment, that's the UK screening position. It's the BHF position. However, the BHF wholeheartedly support genetic testing of affected families and targeted screening, and we've supported that for a long time.
Just a few more questions. Does diet play any role in relieving or worsening the condition?
This for me?
Yes, Angelique.
No. There are no current recommendations to that diet alterations could either make things worse or better.
Okay, and just one thought when you're talking about the swab, I suppose a dynamic emerging from COVID is populations are more aware now of swab testing and things that might make what you're doing just out of bad circumstances, but at least the sense of it that bit easier.
It's interesting because the only reason that I ended up developing the home kit was COVID. So when I enrolled this study at the CRN, I had predicted that I'm going to enroll 800 people. And during the COVID years, I got a note saying that we're going to close down your study because you haven't enrolled anybody. And I said, of course, how can I enroll anybody? Nobody's coming to the hospitals. Everybody's doing everything through phone consultation. So this really pushed me to go and make a home kit to allow this study to continue through the pandemic years.
Yes, good thinking. Liz, a sort of final one for you. You've touched on it, but and you've touched on the range of activities, the kids and all the rest. But this questioner wants to know: are there any restrictions on Bee's life at the moment, or for your son?
No. So at the moment, the team at Greenwich just encourage Bee to do whatever she wants to do, which she's very happy with. And for Frank, no, not until obviously if he was tested and found to be positive, then but they have sort of said we might need to rethink the rugby, for instance, that he does. But at the moment, because it's under 6s, it's relatively safe, and his ECG and echo have always been normal. So yeah, at the moment, not for him at all. And for Bee, no, she just lives her life, having a grand old time, going to the theatre and doing wonderful things. Yeah, so no, not currently.
All right. Well, listen, wish them our best, and thank you very much for participating this afternoon, for sharing your story. Angelique, thank you for sharing your story and your research. It's hugely valuable. And June, thank you too for all your advice and information. Before we wrap up, I'd like to ask you, the audience, a poll question. And how would you rate your understanding now of sudden cardiac death? Once again, 1 is very little and 5 is a lot. I'll just give you a moment to put your position down. And if we haven't managed to answer your question today, then we encourage you to visit our Heart Helpline, where you can contact our dedicated clinical team about your query. And there's a hyperlink going on the bottom of the screen there. That's on the BHF website. This is all made possible by you from your generous contributions and support. If you'd like to make a donation towards our life-saving research, there's a link in the chat box to do so. Live and Ticking is a monthly webinar series, and we strive to produce the best events possible for you, our audience. Your feedback and comments are crucial to help plan and develop future events. So We ask if you can complete the survey at the end of this event or through an email you receive in the coming days. This live and ticking event was recorded and will be available on our YouTube channel from next week. Our next webinar will take place on Wednesday, the 31st of July. This will be a special edition in partnership with Macmillan Cancer Support on the topic of cancer and the heart. You can register using the link in the chat box. Thanks again for joining us, and goodbye.